A very good day, my dear undergraduate and postgraduate students. The topic mucoviscidosis I had chosen as SNP, a short note in pathology. This has been quite common in the postgraduate question papers and occasionally in the undergraduates also. Let us see how we can unravel a difficult topic. When in doubt, delegate. These are the series of subheadings which will take us to the answer. And secondly, you find that we will not miss any component when we write an answer for the exam. Thanks to the schematic picture from LME, and this is an autosomal recessive multiple sulfatase deficiency disorder. Both the parents are carriers over here, in which case 1 in 4 chance is for a child to be fully blown. The introduction for it is as follows. Founded by Peter Paul in this period. He was an anatomist and a botanist. And the gene was cloned in 1989, more than 1800 mutations. It can be mild or severe, based on the quantity or the function of the CFTR gene. A homozygous defect in chromosome 7, 7q31.2 will lead to a full-blown disease. The treatment will be dealt with later, and the most severe mutation is AF508. This is Sidney Farber, who has found or coined the term mucoviscidosis. Thanks to Elsevier for this picture. And this, the thanks should go to Wikipedia, which is a G banding for the chromosome, and in 7, it has been located. The incidence is 1 in 2,500 live births. It is a common lethal genetic disorder, more common in the Caucasians, with pulmonary and pancreatic manifestations. This is the mutation we had been mentioning. And earlier there used to be a saying that one gene is one disorder, and this was a prototype. However, there have been challenges to this particular statement, as we shall be seeing. A very fondling hand for a child who is trying to overcome this disorder with a smiling face. These are, of course, the clinical manifestations you shall go through. There can be sinuses, sinusitis, as well as a nasal polyp, bronchitis, bronchiectasis, sweat gland. There is an elevation of the chloride, and there can be a pleural effusion, cirrhosis of the liver, pancreas, both diabetes as well as an exocrine dysfunction, intestine, classical meconium ileus, and male infertility is also known. And this is a grade 4 clubbing, a pulmonary osteoarthropathy in a case of mucoviscidosis. The symptoms are persistent cough with thick mucus, recurrent sinusitis, severe constipation, poor growth and weight gain, recurrent lung infection, bulky, foul-smelling, greasy stools, diarrhea and dehydration, salty skin, and infertility. Thanks to Radiopedia for this X-ray of bronchitis. This is called the R.A.T. testing, and it is supposed to be immunoreactive trypsinogen test. Thanks to ResearchGate for this reference, and it has been from Russia. So, this is the way of testing for the full term or the premature one. And it has been repeated in this sequence, followed by a sweat test and a DNA test if required. And there can be the variants which can be identified. Ultimately, you make a diagnosis of cystic fibrosis. If there is no pathogenetic variants, follow-up is required. This is the pathogenesis, the ion channels. Normally, you find that this is an exterior, maybe the sweat gland or the sweat duct, and you find that this is the exterior of the cell, and this is the interior, the cytoplasm, along with the gut. Now, there is an abnormality in the epithelial chloride channel protein. So, this is the CFTR protein, which can pass 214, which is closed in a case of cystic fibrosis. And when it is open, you find that it is a two-way traffic. The chloride ion, on the contrary, you find that it can accumulate in excess, leading to an abnormality. There is a hypertonic salty secretion that is due to this chloride ion. And the reabsorption of the sodium chloride is being prevented because of the closed channels. This is again an important one. I would like you people to remember these two terms, which I have again encircled in the picture below. MSD is multiple sulfatase deficiency, and this can result in mucoviscidosis as well. And NBD, this is a formula you people can go through, NBD chloride. This is a cell membrane, bimolecular lipid layer enclosed between two monomolecular layers of protein. And this is a MSD1 and 2, NBD1 and 2. What happens is in cystic fibrosis, there is a transmembrane conductance regulator. And there is also a ABC transporter family. There is a novel chloride channel, the apical membrane where the transmembrane fluids and transport occurs. The two domains forming the channel pore are MSD and NBD. So this is the normal mechanism which we should understand. There are 6 categories. Again, thanks to Radiopedia, wonderful reference. CFTR gene mutations. These are the various classes. There can be a premature stop codons, CFTR misfolding and increased dehydration, mutations and regulation of the CFTR channel. Class 4, again mutations, CFTR ion conductance is being interfered with. Class 5, promoting and splicing, and class 6, there is reduced stability. So these are the 6 grades genetically identified. The morphology will depend on a multitude of manifestations, which can be pancreas. There can be accumulation of mucus within the ducts. There is a distension of the glands. And the adolescence, it is more plugged in. There can be impaired fat metabolism because of pancreatic insufficiency, squamous metaplasia secondary to irritation and infection. In the lung is again one of the most seriously affected organ. You find that there is a mucus plug, thanks to ResearchGate for this picture. The bronchioles are distended, hyperplasia and hypertrophy. And there can be recurrent infection leading to bronchitis, bronchiectasis, and these are the organisms. And there is one sepaceous syndrome with a rare organism which is supposed to be opportunistic. And if you are supposed to identify the bronchial tree, the contrast X-ray or bronchogram is recommended. This is what you people see histologically. So you are able to identify the bronchial wall lined by the ciliated columnar epithelium. There is a neutrophilic exudate both within the lumen as well as outside. There can be specky areas of necrosis as well as calcification. Acute inflammation, viscid mucus, and credit to Shutterstock for this picture. This is one thing that is fundamental, which I would like you people to easily remember. There is a CFTR gene defect. There is a reduced quantity of production of the CFTR protein, defective ion transport, airway surface, liquid depletion is there, and there is a defective mucociliary clearance leading to mucus obstruction, infection, inflammation. Finally, there can be fibrosis and scarring, and there can be an end-stage lung disease. The pancreas, this is what I had said. The epithelial cells produce a phlegm, which is a mucoid secretion. Outgoing channels are blocked. There are distensions with cysts. Glandular atrophy is seen, replaced by fibrosis. Diabetes is an incidental development. The GAT, again, in all the organs, you people can write the viscous plugging or viscid plugging in the small intestine. And there is a small bowel obstruction leading to a meconium ileus, steatorrhea is present. And thanks to New England Journal of Medicine for this wonderful contrast X-ray. In the liver, the biliary canaliculi is filled as mucus material, and the bile canaliculi also show mucinous plugging, ductular proliferation, fatty change, hepatitis, and cirrhosis. There can also be cholecystitis and cholelithiasis, thanks to Whipwell. And this is another picture In the testes, for example, there is an enlargement of the head and tail of the epididymis. Thanks to ResearchGate, there is a testis, there is the enlargement that I see in the epididymis. Other than that, there can be azoospermia, infertility. It can be bilateral, and there can be absence of vas deferens. Seminal vesicle agenesis, or there can be epididymis agenesis thanks to CFTR mutation. And this is the reference for this picture. There is something called as pleiotropic effect in current biology. That is where this picture has been taken from. So this is the ion channel. You find that there is a chloride ions. I told you initially there will be a 2A one, but this is being blocked in a case of mucoviscidosis. As a result of which there is over precipitation of the chloride on the surface, leading to a permanent block as well as the salty skin. ATP bicarbonate, other molecules are also concerned. That is why it is said that one defect, one gene theory is not applicable over here. And here is schematic scholar explaining the development of cystic fibrosis. What are the investigations you can do in this case? The clinical presentation. The expansions I had given over here, which you people should follow. There is a positive NBS, signs and symptoms, as well as family history. Sweat chloride testing can be done. And there can be a CFTR genetic analysis. That is over here. CFTR physiological testing is also done. And NPD is nasal potential difference, which is an electrical test. And once you find that the values are above 60, you find that there is a definite diagnosis of cystic fibrosis. And also when there are two mutations which have been identified, or there is a CFTR gene dysfunction, all of this point to this. Whereas if the value is reduced, there are no mutations, and if the function is preserved, CF is unlikely. These are the references for this wonderful presentation. Shepard, Robbins, of course, it's a wonderful one. Cystic fibrosis from Radiopedia and Rare Disease Advice. I hope you people are able to see the gladness on the face of the child and the solace from the mother. The treatment can be dietary, physiotherapy, transmembrane regulation, and these are certain drugs which have been given, lung transplantation, and whenever there is a transplant, there can be an associated malignancy which can also be borne in mind to be treated. And after all, whatever be it, there is a living with hope. Thank you.